Good morning, everyone. Good afternoon. This is Dan Milner from ASCP. Thank you so much for joining the PathologistsECHO. Today, we're very excited to have hopefully a full echo with Dr. Steve Kusick from Phenopath in Seattle, who is going to talk about flow cytometry and the modern ways that we can use that in Africa. And then we have two case presentations, one from Carol Akola in Uganda on flow cytometry and hemepath, and the second from Deo Ruhangaza in Rwanda on a hemepath case without flow. And what we would like for them to do is really help us contrast and compare the challenges of having and not having flow for hemepath in Africa. Just as an aside, there is a really big effort right now with some of our industry partners to put flow in Africa, and the feasibility of that is becoming a reality. And so if your site is interested in flow cytometry and does not have it, or has flow cytometry and wants to help other sites get it, please do let us know and we'll be happy to involve you in that process. So without further ado, I'm going to turn it over to Dr. Steve Kusick, who will introduce himself. Dr. Kusick, please go ahead and share your slides.
I guess desktop one. Let's see, share. Oh, there's something about getting secure access. What is this? You're not Zoom, okay. It wants, Dan, apologies. It wants me to leave the meeting and then get back on or something. Can you see my screen or not?
No, you might need to reboot Zoom if you just give it permissions. So
yeah, so we're gonna Steve, why don't you go off and come back on, and then while you're doing that, I will just talk to the group about upcoming sessions. Okay. Great. So while Dr. Kusick is rebooting, I will tell you, as you probably all know, Zoom is notorious for asking you to update something right when you're supposed to present. So it's very frustrating. So just as an FYI, next week is our next Africa Calls Cytology session that Dr. Leslie Lomo and Dr. Ali Lowe have been organizing. I know those have been very popular, and they have that speaker all lined up. I will be sending you the details for that before the end of this week. For next week. And this is a little bit of a tight schedule. We have one this week, one next week, but then the schedule will calm down a little bit. And what you will see in your invitation boxes coming forward are either an Africa Calls Cytology, which you're used to, but a new Africa Calls Pathology, which is the same style as Africa Calls, but for a histology approach or a pathology approach. So more of a long informational didactic, which should be very exciting. And then we're having the PathologistsECHO, as you're participating in now, where we have a short didactic and then two case discussions. And then we're also adding a CytologistECHO, where there's a short didactic presentation on cytology, followed by two case discussions around cytology. So if you are interested in that approach, like Dr. Lomo did a few weeks ago, please do let us know if you'd like to volunteer further. We have a couple of volunteers already, but we can always use more volunteers, or if you'd like to volunteer for PathologistsECHO. So now I think Steve is back on with us.
Okay. Can you folks see my screen?
Yes, but we see your email. Now we see your slides. So if you start your slideshow.
All right.
There we go. Awesome. And you might need to scroll to your first slide.
Yeah.
Perfect.
All right, okay. Sorry about that. It's
no worries. No worries. So
firewall was just put on this computer, which is a company computer. And
no worries. No worries. We understand. Okay. Just as an FYI for everyone, before Dr. Kusick starts, if you have a question, please put it in the Q&A box, which is at the bottom. And Dr. Kusick and I myself will help answer those questions. And then when we conclude today, Ken Landgraf will wrap it up with some announcements we've done. So Dr. Kusick, please go ahead.
Okay, thanks. Sorry, everybody. Yeah, I'm going to talk a little today about just real basic aspects of flow cytometry. And, you know, one of the things that sort of the set of ideas that occurred to me about 10 years ago when I started getting involved in sort of global oncology and thinking about deploying flow cytometry in sub-Saharan Africa in collaboration with a number of people, including Dr. Achola, who you'll hear from, and kind of talk about it and why I think it's a great technology for Africa. And I'm in my 25th year of hematopathology, attending first at the University of Washington in Seattle, now at PhenoPath in Seattle, which is part of the larger Quest laboratory system. Okay, so what is flow cytometry for those who aren't as familiar with the technology as maybe some of us who use it every day? Well, one can really think most simply about flow cytometry as a method for evaluating particles in solution. And those particles can be anything from plastic, small plastic, what we call microbeads or microspheres, to actual organisms such as bacteria or yeast or fungi, or in the case of cancer medicine, human cells. And so what we do kind of at the lower left in the process of preparing cells for flow cytometry is we label those cells or proteins on or inside those cells with specific monoclonal antibodies that specifically recognize those particular proteins. And each of those antibodies to a specific protein will be tagged with a different fluorescent molecule. And that's critically important because when in step 2 in the flow cytometer, when the sample, which is a suspension of cells in solution after it's been mixed with the antibody cocktails, typically to multiple antigens at the same time. We actually look at 10 at the same time in our lab and in the labs we collaborate with in Africa. That suspension is introduced into the cytometer, and through a principle called hydrodynamic focusing, which is shown in the kind of upper middle of this diagram, where you see a bunch of red particles that are actually focused into a single file by a higher pressure fluid stream surrounding them. When that hydrodynamic focusing occurs, it allows cells to actually be interrogated or evaluated by the cytometer individually. So the real advantage of flow compared to other techniques that I think the audience would be familiar with, like routine histology, is that flow can get a lot of information reliably about a single cell at a single time. And so anywhere from 1 to 4 or more lasers in a given cytometer can illuminate excite or illuminate the fluorescent tags on the proteins of given cells. And when those fluorescent tags are excited by the laser light, they go to a higher energy state, and then as they return to their lower ground energy state, they emit radiation in the form of light of various wavelengths. And then the third part of the cytometer, the optical system, partitions those wavelengths into different areas, high versus low, et cetera. And since we know what the fluorescent tags are associated with individual proteins, by looking at the type of light emitted for each individual cell, we can deduct or deduce what proteins are expressed by that cell, either on its surface or on its size, or on its surface or inside it. And then using the computer system attached to the whole flow cytometer, the software in the computer system will allow a visual representation of or essentially a transmission or conversion of the light energy that's emitted from the fluorescent tags to electrical impulses that we can measure on a screen. And so that's the output are those dots that we're used to seeing, or dot plots, each dot representing a single cell, and the cumulative fluorescence from all the different fluorescent tags used to look at it. Okay, so what do we measure in flow cytometry? We can measure kind of 2 main features of particles, and we'll restrict this to human cells, potentially cancer cells. So there are generic light scatter properties that any particle in solution has. Forward scatter or forward angle light scatter is roughly proportional to cell size. So very small cells like mature lymphocytes or immature precursors in the marrow like hematogones have very low forward scatter. Larger cells like large cell lymphoma or even monocytes and granulocytes have higher side scatter. And a second feature is forward, higher forward scatter. A second feature is side scatter or right angle light scatter. And that is a measure of the complexity of the cytoplasm in a given cell. So again, lymphocytes with very small amounts of relatively non-complex cytoplasm have low side scatter in addition to their low forward scatter. Highly granular cells like neutrophil series cells or eosinophils have very high side scatter, so that helps separate them. And then there are two actually true fluorescent features. Since forward and side scatter really aren't fluorescence, they're just kind of light scatter properties, but the fluorescence features are intrinsic fluorescence. So all cells have biological molecules inside them, particularly complex ring structures, things like NAD, flavins, nucleic acids, which just fluoresce when exposed to different light sources. And then there's extrinsic fluorescence, which includes, most importantly, in flow cytometry, the bound fluorescently labeled antibodies we use to identify specific proteins on or inside the cell. But it's also important to remember that dyes that bind DNA that have fluorescent properties can be used to measure things like cell ploidy, the DNA content of cells, or how fast cells are turning over in terms of S phase fractions. So flow has some real advantages. We mentioned you get all this information about individual cells rather than a group population of cells. So it's kind of an alternative to histology. And because of the increasing complexity and sophistication of the technology, we can now look at many parameters at the same time. So in our laboratory at Phenopath and the labs I collaborate with in Kampala and Eldoret in Africa, we're looking at 12 parameters, so forward and side scatter plus 10 antibodies. It's perhaps most importantly for places that use it, it's very rapid, so we can diagnose life-threatening blood-related cancers like acute leukemias or aggressive lymphomas. In patients who may have medically urgent conditions like superior vena cava syndrome, we can typically make those diagnoses in 2 to 3 hours. And in that time, not only process and analyze a sample by flow cytometry, but also make 1 or 2 cytology slides, smears, or cytospins. So for those of us like myself who are hematopathologists, we can morphologically correlate what we see under the microscope with what we see on our flow cytometry software. We can be very quantitative, as everybody knows, in terms of HIV, CD4, HIV monitoring with CD4 counts. It's very reproducible. And it's actually flexible in that, if we have 10 parameters or 10 proteins we can look at, we can kind of change the organization of our assay as our clinical needs change. A disadvantage, as I sort of implied, we don't have histologic context. In terms of making definitive WHO diagnoses, which typically lack histology, there are actually very few cases, so very few entities that we can do that solely by flow cytometry. Certain cell types are not easily identified, like Hodgkin cells, or are underestimated, like the neoplastic cells in myeloma. Obviously, it's dependent on viable material, so at most we have about 72 hours after a sample is obtained to analyze it. And even if we can get it again, the clock is ticking. So we always run our flow lab at Phenopath we do a full shift on Saturdays because we know we're getting material that's been collected from our clients Thursdays and Fridays. And one thing that I'm trying to do, internationally as well as in the United States through some of my teaching that I've done, is to try to increase the overall level of expertise in flow cytometry among pathologists, my colleagues. There are a whole variety of clinical flow cytometry or FC assays shown here. Many of them enumerate, just quantify different cell populations. I'm just going to direct you to the lower, the last bullet point in this list: leukemia, lymphoma, myeloma analysis, which is what I do almost exclusively in my lab to look for neoplastic populations. And this type of analysis has got some unique aspects. So again, we're not really enumerating, quantifying cell types like CD4 positive T cells or fetal red blood cells in the maternal circulation, but rather we're looking for abnormal populations whose identity we don't know. There may be a clinical concern for a specific type of neoplasm, but we certainly don't know that until we look at the data. And importantly, with aging populations that we see in my practice, which is mostly adults, there may be multiple abnormal cell populations present, and not everyone is as clinically significant as the others. So we need to be very aware of these pre-malignant entities like MGUS, monoclonal gammopathy of uncertain significance, or MBL, monoclonal B lymphocytosis, and realize even if we see them, they may not ever threaten the patient's life. This is a very complex slide, but I was part of a 35 person sort of flow expert consensus conference back in 2006, which just decided what proteins or antigens should be a part of flow panels for different specific indications listed on the left in very small print. The antigens, many of which have CD or cluster of differentiation designations, are listed along the top, and the red colored boxes indicated antigens that there was a high degree of consensus should be part of any flow panel to look at for specific indications. So for like anemia and pancytopenia, CD20, a B-cell antigen is listed red across the board because we want to look for B-cell lymphomas. Okay, and just the final thing to keep in mind about leukemia, lymphoma, myeloma flow, because we're looking for abnormal populations, all of us who practice flow on a daily basis really use a difference from normal approach to identify the abnormal. So really the first step in learning flow to apply to identifying neoplasms is to understand what normal looks like. And this requires months to years of training, but these are just some really nice diagrams from my ex-colleague Brent Wood and Mike Borowitz in an older publication, but really show for each of the lineages that we're concerned about identifying malignancy in. There's a variety of characteristically expressed proteins or antigens listed on the left here. And you can see from early in maturation to late in maturation along the left, there's a very characteristic expression pattern from light red being low level expression to dark red being high level expression. So for example, CD38 here at the plasma cell stage is very, very dark red because it's very highly expressed in plasma cells. And one needs to know all of these antigens and more to really be as competent and as able as possible to identify B lymphoid malignancy throughout B-cell maturation. T cells which mature in the thymus, unlike B cells which mature in the bone marrow. Again, the same kind of knowledge needs to be had by the flow cytometrist to understand difference between normal T cell maturation and abnormal or neoplastic maturation. And then for granulocytes, even more complex maturation from blasts all the way to neutrophils. So there are a lot of antigens that one needs to be aware of. And finally, for monocytes, again, a number of antigens, and less commonly used, but other lineages that we think about are erythroid cells, megakaryocyte cells, or platelet producers, even things like dendritic cells. So kind of my last real image here is when one gets a full understanding of these patterns of maturation as cells develop in the bone marrow and the thymus, one can actually get a very reproducible set of images that look at the two-dimensional images that look at the pairwise expression patterns of two different antigens on different cell populations. So this is just normal myeloid maturation shown in these dot plots. The total bone marrow cells using this 10-color approach, 12-primer approach, are shown in the upper left. CD45 versus side scatter, which is a nice way to separate all the different major populations. And then if you gate on the area with basophils and blasts, you see some patterns of maturation, particularly among the red-colored myeloblasts or progenitors. And then if we look at the lavender-colored monocytes or the dark green-colored neutrophil series or the orange-colored eosinophils, we get very characteristic patterns. So one needs to know this not just for myeloid cells, but for B lymphoid cells, T lymphoid cells, et cetera, to be an effective diagnostician. So thanks very much for listening. This is the Seattle-based nonprofit, the BLFA. If anybody wants to go see our website, there's a lot of details about our pathology improvement program that's helping flow labs in Kenya, and in Uganda, and hopefully in additional places. And that's all I have for now. Thanks for your attention.
Thanks so much, Steve. I really appreciate it. And I hope that this was a great overview for everyone. I'm sure there might be some questions. So if we have some questions, brief questions, let us know. I don't see any in the Q&A, but maybe people will think of them as the others are speaking. Carol, I see that you're on. So if you can go ahead and turn on your video, if that's possible. You don't have to, but we can switch you over to sharing your screen. She's muted right now. Carol, you're muted. So there you
Hello.
go. Hi, Carol. How are you?
Fine, thank you.
Good.
So
Good morning or good evening, Carol.
Good evening.
Can you go ahead and share your screen for us, please?
Yeah. Can you see my screen?
Yes. Go ahead and start the presentation and we should be good.
Okay, so my name is Dr. Caroline Achola. I'm a pathologist. I work with the Central Public Health Laboratory in Uganda, and I directly take care of the flow cytometry lab that was set in 2018. Today, I want to present one of the challenging cases, interesting and challenging cases we've seen recently. He's a 19-year-old male who was referred to the UCI with a diagnosis of chronic myeloid leukemia, chronic phase. And at the time of presentation, his total white count was 222, with an absolute neutrophil count of 113, and absolute lymphocyte count was 87, and the monocyte was 20. And then his HB was 4.8, with a platelet count of 22. His story was a 2-month history of fever, anemia, and body pain. He also had neck and facial swelling and associated B symptoms. The baseline investigations that were done, the LDH was 779. The liver and renal functions were normal. Importantly, the abdominal ultrasound scan showed a hepatomegaly of 18.3 and a splenomegaly of 17.7 centimeters. And he had generalized adenopathy, with the largest being 3.4 by 1.7. His Philadelphia quantification was negative. And then a bone marrow was done. That was in June. And the report showed features of chronic myeloid leukemia, chronic phase. A sample was also sent for flow cytometry that showed a left-shifted marrow with no obvious blast population. So this is the first flow report that was run in June. And the dark green are the granulocytic population. And then the light blue in the left upper corner is the lymphocytic gate that mainly has the B and T mature lymphocytes. And then down here we have basophils, or if it's acute leukemia, we can have them falling in that gate because they're DIMA for CD45. So what this flow generally shows us, we have a mature neutrophil expansion that was really consistent with the clinical presentation of the patient. So the patient was given a tyrosine kinase inhibitor, but showed no response. And during the time he was receiving treatment, he was clinically progressing on treatment with rising white counts and increasing hepatosplenomegaly. So that prompted a review. So there was a review of the first biopsy that still was commented as the chronic myeloid leukemia chronic phase. So they did a repeat biopsy about 2 weeks after, and it showed hyperplastic marrow with the M&E ratio of 15:1. And notably, there was an increase in the granulocytic precursors with peaks in more mature stages of the myelocytes and the segmented neutrophils. Also, there were monoblasts and myeloblasts that constituted 25 to 30% of all nucleated cells. So at this point, it was taken as a blast phase of the CML. So it was the working diagnosis that was given back was acute myeloid leukemia. So subsequently, this patient was switched to chemotherapy using AML protocol, and he had a marked response. After end of induction, we had a bone marrow reevaluation for treatment response, and he was morphologically in remission. Around that time, again, flow was sent. We had another marrow aspirate sent for flow, which showed a 28% of the nucleated cells in the marrow being immature T lymphoblasts that were characterized by bright CD45, HLA-DR negative with a bright CD7 and CD34 negative. So basically, this is the flow images for the second biopsy. So what I have colored blue, dark blue, are the immature, abnormal immature T cells, and they actually constitute the majority of the T cells, about 85 to 86% of the total lymphocyte count. So we see it's CD34 negative, and really we didn't have that. And then we have a heterogeneous expression of CD33, but basically the majority of the population remain HLA-DR negative with CD7 expression, bright CD7, and a low CD3. A low CD2. CD3 was not positive, and the other T cell markers. So with that, we considered that we have an immature T cell proliferation, and we are thinking it's a T cell blasting away from a myeloproliferative disorder. Again, because of the T cell and the typical flow picture, we again asked for a review, and the comment that was finally agreed on by the pathologist was that it's a myeloproliferative neoplasm, non-CML because of the Philadelphia negative, and morphologically it was non-CMML. Interestingly, we also noted that there was a prominent eosinophilic precursor, but with a low blast count in the review of the second marrow aspirate. So we are at a point we are considering, could this be a chronic neutrophilic leukemia? So at the moment where we stand, it's the working diagnosis that the patient is being treated for is that we have a myeloproliferative neoplasm with a blast transformation, likely an early progenitor that can transform in either a myeloid or a T cell. But the clinicians have decided, since the patient showed marked response to an AML protocol, this patient is home after completing the consolidation. So we wait to review him. Thank you so much for listening. Over to you, Dr. Dan Milner. Hello.
Not sure if Dan is still on, but let's see, do we have any questions?
There's a question about, I'm just looking at the Q&A, question about the cost of the flow cytometry machine and the reagents. Do you want to take that, Carol, or shall I?
I think you're better placed to
Okay.
take that. Yeah.
Okay, so hopefully everybody can hear me. This is Steve Cusick, again from Phenopath and BLFA. So the laboratory that Carol works in at the Uganda National Health Lab Service, or Central Public Health Laboratory in Kampala, is actually a laboratory that she and Dr. Susan Nabata, who's the executive director of that institution, and I and our very close collaborators from Beckman Coulter all launched together back in 2018, at the end of 2018, starting initially with a 5-color 4-tube flow cytometry assay that we actually developed and validated in my lab at Phenopath, and then Beckman Coulter kindly produced for us. And now we've transitioned to a 10-color, really state-of-the-art 10-color assay using dried down antibody reagents that are cold chain independent. That's actually what we use for the 5-color assay as well. So we get around potential cold chain, breaks in the cold chain. But this particular lab, I basically pitched the idea about setting these labs up, and we have a sister lab in Eldoret, Kenya, at the Moi Teaching and Referral Hospital, AMPATH Research Lab. Early 2018, I pitched this idea to Beckman Coulter, and they really liked it. We were initially going to use refurbished older 5-color instruments, but they very kindly donated a 3-laser 13-color instrument to each of those 2 locations. So that, and this was kind of a pilot project to see if we could transition laboratories that, at least the one in Eldoret, had been doing its own sort of 4-color flow, and as well as T-cell subset work, and see if we can transition that lab. And I'm not sure, I believe didn't have a lab in Kampala at the UNHLS, and to see if we could launch a high complexity flow lab successfully. So it was kind of a pilot project, and so some of the initial outlay was from Beckman Coulter, and then the BLFA, my organization, bought like a cell counter, cytocentrifuge, some things that were necessary to have in the lab as well to help launch it. And since then, between the BLFA and Beckman Coulter, we've been doing a lot of the funding, and also contributing to some of the salaries for employees in the lab. Some of that's come from the employees' salaries themselves from the UNHLS or from the institution in Eldoret. Moving forward, we actually, by transitioning to these 10-color reagents that are off the shelf, they're actually much cheaper to obtain than the custom 5-color reagents we started using, because the 10-color reagents are mass produced. It's actually in the United States and Europe, those are approved diagnostic entities that are recognized by the FDA in the States, and the CE group in Europe. So the price point per tube is actually quite cheap. Something, it can be something on the order of $20 to $30. And so the new approach now is to use a single screening tube that actually has, it's going to be fairly complex. It's going to be a 10-color tube with 15 different antibodies in it. And if in the 50% of people who are negative for an obvious malignancy with that tube, we simply stop the evaluation. We're not trying to diagnose something early like myelodysplasia, which would be much more morphologic and maybe molecular call. We're trying to identify definitive malignancy. So then the other 50% of people where we find something, then we reflex to an appropriate lineage associated tube or tubes, like one additional T cell tube or 2 myeloid tubes. And so with that type of algorithm, where we really use a very thorough screening tube, and then only you do additional analysis for people with obvious malignancy, the price point per assay, I've calculated it based on certain assumptions, it's well under $100. So again, not inexpensive, but a fraction of the cost in developed countries, and something we think is potentially sustainable. So kind of a long answer, but it's critically important to this whole project is making this sustainable. I mean, Dr. Carroll, who's trained with me, to learn the flow software and some of the nuances in this complex case we both looked at that she presented so nicely. Really, we all want to make this sustainable. So 20 years from now when I'm retired, the labs can be a going concern in Africa, completely independent of my involvement. The instrument we're using is, there was a question about, it's, somebody mentioned something about a fax caliber. That's a 4-color instrument. That was actually the instrument that we replaced in the lab in Eldoret, Kenya. These are 3-laser, 13-color Beckman Coulter Cytoflex instruments. And the hope is that at some point we'll be able to move from the 10-color assay we have to a 13-color assay. So be able to look at least 3 more, antigens in that single tube. I think that's all I have on that note. Kind of a long answer, but it gets at the real core of why we're doing this project and what we hope to achieve. So shall we go to the next presentation, Ken?
Yeah, that sounds great, Steve. Thank you. So Deo, are you ready to present?
Hello, good afternoon and good morning, depending on where you are. Yes, how do I share my screen? Or I think I sent the slides to Dr. Dan also.
Yeah, Carol, you should put, stop sharing. Perfect.
Yeah, you should be able to share now, Deo.
All right, thanks. Are you able to see my screen?
Yes, we can.
Thank you very much, and I want to thank Danmin and the ACP to give me this opportunity to share this case. And I'm going to talk about non-lymphoid hematopoietic diseases in extranodal and extramedullary location that I found as a challenging diagnosis in our limited resource settings. My name is Deo Ruhangaza. I'm a pathologist here at Butaro Cancer Center in Northern Rwanda. So for this, we're hearing the institution for the first time. This is our institution here at the hospital, basically a public institution with a cancer center. And we have an affiliated academic institution, the University of Global Health Equity. And both institutions are based in the rural northern part of Rwanda. Okay. So as a short introduction, the non-lymphoid hematopoietic neoplasm in extranodal or extramedullary sites be located in musculoskeletal or skin are rare in our routine practice. And this is part of the diagnostic challenge because of the infrequent nature, the non-specific picture on routine and lack of histochemistry strain and lack of expert review in case we need a HEMPAT for consults. So we don't have flow cytometry instrument, unfortunately. So for all HEMPAT cases, we rely on morphology and immunohistochemistry only. So this neoplasm may be often misdiagnosed on initial biopsy and lead to wrong patient management. So I've here selected some of the commonly described lesions in the literature. There are mainly case reports that are shared, and they are basically in 3 categories: the histiocytic neoplasm, dendritic cell neoplasm, and myeloid neoplasm. So in the histiocytic category, you can talk about the Langerhans cell histiocytosis, the indeterminate cell histiocytosis, Erdheim-Chester disease, the Rosai-Dorfman disease, and histiocytic sarcoma. So in this category, what we sometimes see here as the Rosai-Dorfman diseases and histiocytic sarcomas. For the dendritic cell neoplasm category, we can talk about the follicular dendritic cell sarcoma, interdigitating dendritic cell sarcoma, fibroblastic reticular cell tumor. This one is really very rare, and I'm not here in our institution, but we have, for example, 1 or 2 cases of interdigitating dendritic cell sarcoma that have been treated here. For myeloid neoplasms, they're mainly myeloid sarcomas and blastic plasmacytoid dendritic neoplasms. So for this neoplasm, there is really no standard oncology treatment protocols here in our setting, but when we are able to reach a proper tissue diagnosis, so we take the case into a discussion through our multidisciplinary tumor boards that we have every Thursday, and we are able to provide good treatment decisions. So I'm just going to share one case from our lab here, and this was a 9-year-old woman with a 2-year history of a slow-growing, indurated, and ulcerated skin mass at the interior medial aspect of the left lower leg. It was fixed and tender. That was the approximate size, 5 by 6 centimeter, and with covering ulcerated skin surface that had purulent discharge, probably a wound superinfection. This young patient has an unremarkable past medical history, and she tried to use traditional herbs without improvement. This is something that we commonly see in our settings. Most of the time, patients before going to the hospital, they try traditional medicine at the community. So the patient has excellent general status, and the routine blood count and routine lab tests were within normal limits. And this is the picture of the lesion, how it was looking like. As you can see it, very painful and itching, and patient could not sleep. And we did a biopsy. You can see here the routine H&E stain with this diffuse infiltrate of small round hyperchromatic cells. So the ulcerated part of the surface is not shown in the picture. So this is the more high power. That's how the tumor cells look like. So can identify them with this folded irregular nuclei, relatively distinct nucleoli. So we have a limited panel of IHC, and what we could have locally was a positive CD45 and a partial positivity for TDT, and negative CD3, CD20, and a PO. So with the panel and the clinical picture, it couldn't give us really a straightforward diagnosis, and we ended up sending the case to the tissue block to Brigham and Women's Hospital in Boston. So we have the partnership with the laboratory, and we can send challenging cases for expert opinion and additional testing. So they did additional testing, and the tumor cell were expressing CD4 and CD56. They were positive for CD123, TCL1, and CD33, but they were negative for CD10, CD19, CD34, CD7, and CD5. So I couldn't put all the micrographs for these 15 tests that were done, but we selected few of them. This is TCL1, that is positive. This is CD123, that is positive. And this CD56, that is positive. So the diagnosis was a blastic plasmacytoid dendritic cell neoplasm. And, I mentioned it in the categories during the introduction. So the BPDCN is rare, and derived from precursors of plasmacytoid dendritic cell that are considered to be of a myeloid lineage. And the most common location, the skin and subcutaneous tissue in almost 60 to 100% of cases. So this neoplasm has a bone marrow involvement commonly at presentation, but we did bone marrow biopsy and the bone marrow biopsy was normal in our patient. So the histology is that one I described, the sheets of primitive cells infiltrating the dermis and subcutis, and the helpful combination of IHC would be a co-expression of CD4 and CD56 with a lack of other T cell markers, as you've seen in the panel that was done. So it has variable positivity for TDT with negative CD19 and CD3 and MPO. So other tests that are positive is the TCL1 and CD1.3. So to reach the diagnosis, you really need that combination of IHC panel results. So on the morphology alone, it can be really challenging to make a diagnosis. One would think with that type of morphology, acute leukemia with extramedullary involvement, we would have some often associated the blood count changes and also positive other blast lineage markers. Especially when it is on the skin location on sun-exposed areas. This may mimic Merkel cell carcinoma, the neuroendocrine tumor, but this would be CK20 dot-like positivity that we all know about Merkel cell carcinoma. So it can also mimic AML with leukemia cutis, and then this will be a TCA1 negative. So how was this treated? As I said, we don't have standard care protocol for this neoplasm here. So we ended up taking the case, the multidisciplinary tumor board. This patient was a young patient with excellent performance status, and everyone was really wanted to do something to treat the patient. So in the literature, it is reported that this may respond to routine standard protocols for acute myeloid leukemia, acute lymphoblastic leukemia, or aggressive non-Hodgkin lymphoma regimens. And I've shared an article discussing this, the therapy for blastic plasmacytoid dendritic cell neoplasm. So we decided in the tumor board to use the intensive systemic chemotherapy regimen that we use here to treat acute lymphoblastic leukemia. So this is the protocol I got through from the oncology team. The protocol that was used to treat this patient, a 4 weeks of induction phase and 4 weeks followed by consolidation phase, interim maintenance phase, and delayed intensification phase, and the maintenance phase that continued for a total of 5 years, and regimens on each phase are mentioned in this table. So these pictures are comparing the lesion before starting the treatment as I showed it, and at the end of interim maintenance phase, you can see this really dramatic response to treatment. So the patient was followed up and completed the treatment. Now 2 years has passed, there's no recurrence until now, and patient is just being followed up in the oncology program. So for those who might be interested to see the whole case report, we ended up publishing it, and this may help you to identify case report. In conclusion, the non-lymphoid hematopoietic neoplasm in extranodal site present a diagnostic challenge in our resource-limited setting. We don't have a standard treatment protocol, but when we reach a confirmatory tissue diagnosis, it might help the multidisciplinary tumor board to decide what to do for the patient. So sometimes an extended panel of immunohistochemistry and expert hematopathology opinion is often needed. And as you can see, some of them can respond very well to routine regimen that we use to treat leukemias or lymphomas. Yeah, let me stop here for any question or comment. Thank you very much.
Thanks, Teo. So let's give it a second and see if any questions come in.
Can I, this is Steve Cusa, can I just ask a question?
By all means.
Yeah, this is a really nice example of, for this particular entity, blastic plasmacytoid dendritic cell neoplasm we see about once or twice a year in my own practice, which sees a lot of strange tumors, where, yeah, flow actually can get you most of the way there, but the differential between myeloid sarcoma and BPDCN really is resolved by plasmacytoid dendritic cell, more specific markers like TCL1, which can be done by flow, but we do by IHC. And there's another assay we're validating in my lab right now, TCF4. So flow will get you much more quickly to that differential, but actually this one really requires the full armamentarium of diagnostic modalities, because IHC is really what seals it even in my lab. Again, some people can do TCL1 by flow, but that might be in Rwanda, Dr. Dio, that might be an assay you folks might want to work up. TCL1 is critically important for this differential that you showed in this case, but also for T-cell prolymphocytic leukemia, TPLL, TCL1 is one of the hallmarks because of the real common TCL gene rearrangement on chromosome 14 that leads to its overexpression. And those are difficult cases to diagnose without it. So, if you're ever looking for additional antibodies to bring in-house, TCL1 is not an unreasonable one to consider. But yeah, this is a great example of kind of how everything needs to be aligned diagnostically.
I see one question asking about a publication detail on the second to last slide, but it looks like we might have lost Deo. If so, we can send that out by email. All right, well, seeing no more questions, I'd like to thank everyone for participating today. It was great having you all here. Like Dan mentioned, we will have a recording of this session available, posted on our landing page in the next day or two. Additional details will be coming out soon about Africa Calls Cytology next week. Thank you again for participating, and we look forward to seeing you on the next call. And thank you to all of our presenters today.